immediately my life has deteriorated into just like lying.
Yeah. That's what I'm scared of doing as well.
Hello. How are you? Yeah, good.
It was smashed there like 4 times. Like I was
Barry, give him that. Yeah, no, he's very well prepared. Don't worry if you don't need it.
I know exactly.
All right.
What do I gotta do?
Should be all good to go.
Oh my god, you're amazing at this.
So, yep, I think sound's working.
Yeah, okay, see.
So I think
Is this way? Okay, awesome.
cool. I think we should be all good to
Do I need to, is there any like microphone or anything that I have to?
Nope. You can, I think probably if you stay around here.
Yeah. Okay, I'll do no running into the audience.
Yeah, sure. And do you want me to publish the slides online?
Sure,
Good?
go for it.
Awesome.
And how long?
Should we go for?
Yeah.
I reckon like 7:30.
Okay, I want to be sure.
Yeah. Like as max.
People
As
may
max,
die.
as max.
Okay.
Yeah.
Awesome. Sounds
Awesome.
good. No worries. And should I wait around or should I just start?
Maybe just wait until maybe 10 past.
Okay, sounds good. No worries. I'll start because it's about 10 past. So I've been given the topics of the topics of contraception, infertility, and antenatal care, which is pretty like a huge amount of content to cover. So I'm going to get real here. I don't think I can necessarily cover absolutely everything, and this is not a replacement for you guys studying, unfortunately, as much as I wish that it would be. And instead, I'm going to sort of take my usual approach to giving these lectures. That figure of 1 hour 20 is going to be shorter than that. In fact, I should time myself because I think that all of you will zone out if I go for that long. So there's way too much in this topic to cover everything, and you're here to pass the exam, and I know this. So I'll cover more than you need for the exam, but I'll try and point out and emphasize particularly high yield topics that I've seen come up in multiple papers, etc. And I know that some of you may not have looked at women's or may not have done women's yet. So I've sort of tried to keep it at a content level which is accessible, but there may be some concepts that I just haven't noticed are potentially unknown if you haven't done it before. So it might be worth a rewatch as you sort of go through, you know, towards squat back and stuff like that, when you might be able to get the hang of everything. Feel free to ask me questions as we go along. Just raise your hand and I will get to you whenever I notice you. So I'm going to pretty much leap straight in. So contraception and the combined oral contraceptive pill. So all of you should know the ins and outs of this completely, as there's a chance that you will have to explain it, have to counsel it in OSCE, or that there might be some weird questions on it during an exam, because it's the most common form of contraception. It's used a lot as it's highly effective and it's reversible. So it's called combined because it's a hormonal contraceptive, and it has both estrogen and progesterone, which is what the combination is. And it works in a number of different ways. Have a basic idea. So by giving them the hormones, you suppress ovulation by inhibiting FSH and LH. It also works to mature the endometrium, and it thickens cervical mucus, which means that it can be more difficult for sperm to penetrate the cervix. Comes in sort of 2 formulations, low dose and high dose, and I'll kind of touch on when you might use one or the other. And it has a failure rate that is actually sort of quite high when you think about it, of 0.3 to 8%. And that's because it requires you to remember taking it. And so the failure rate is almost entirely dependent on compliance. There are monophasic, biphasic, triphasic formulations, which refer to the amount of hormone in the pill over the month. You don't need to know about it, to be honest. I really don't think you do. They really have no efficacy advantage. So, you know, if the patient asks that in a counseling station, you can say that. And they're just more complicated. There are also 4 generations, which I also don't think you need to know. But maybe you should know 1 or 2 of the more common types of pill that you might counsel someone about. So Levlan or Levlan ED is probably the most commonly prescribed combined oral contraceptive pill. It's a 2nd generation. I don't, again, don't think you really need to know that. But it's low dose. It's very effective at regulating menstrual cycles. And Yaz is another name that you might throw out in a counselling station. Because it's a 4th generation, and that 4th generation is the anti-androgenic generation. So it inhibits androgens. So it's particularly effective in PCOS, which is polycystic ovarian syndrome, which is very common in women. And so you may need to know the name of a 4th generation to throw out there if that's in an OSCE station. Because it's anti-androgenic, it also reduces symptoms like PMS, bloating, and perception of weight gain. And there's one sort of side effect that I don't really think you need to know, but hypokalemia can be a side effect of Yaz. As I mentioned, you really should know the ins and outs of the combined oral contraceptive, and that includes the benefits and the risks and the contraindications, both absolute and relative. Benefits and risks, you can sort of look at this slide in your own time, because when I run through it, you're going to forget it immediately. But the way that I sort of think about talking about benefits and risks are the things that estrogen and progesterone might cause. So estrogen particularly increases your risk of clotting, so DVTs and circulatory problems, and estrogen also modulates your risk to certain cancers. So bear that in mind. And progesterone, I think about as the shit hormone. It makes you fat, makes you sad, it gives you headaches, it makes you nauseous. So if you sort of know the general side effects, and it also gives you stasis. So women can have cystitis because their bladder isn't particularly, they can have cholestasis. So you might have gallbladder disease as a risk. So if you think about all of that in your mind, you can pretty much summarize the benefits and risks, sort of thinking about that. So benefits, it regulates your menstrual cycle, decreases dysmenorrhea, decreases menorrhagia. You have less benign breast disease and ovarian cysts because you're sort of regulating your hormones better, and similarly improves endometriosis and fibroids. The modulatory effect on certain cancers is different, so you sort of need to remember which ones it's good for and which ones it's bad for. So it reduces your risk of endometrial and ovarian cancer, and it decreases PMS, improves acne, regulates your cycle. So it's quite a nice pill for a young woman to go on, say. Risks, it's metabolized by the CYP system, and there are many drugs which you may remember that sort of interfere with that. The main one which I would remember in a counselling style scenario is anti-epileptics. So if they're on a drug like an anti-epileptic, which accelerates this system, it reduces the effectiveness of the drug, which is particularly bad in a contraceptive where you don't want to get pregnant. So sort of think about that in your counselling. Think about these estrogen and progesterone effects again. So increases their risk of DVTs, hypertension, stroke. Progesterone side effects, mood and libido changes, headaches, weight gain, nausea, vomiting, cystitis, gallbladder disease. So if you sort of have a good idea about the hormones and the way that they work, you can really summarize this benefits and risks without having to memorize anything. And similarly, so the same goes for absolute and relative contraindications, right? So you only need to remember a few things. So circulatory disease is very related to the fact that they can get DVTs. Migraines and migraines you should remember, and various factors sort of related to estrogen. So think about migraines. So if they have focal neurological symptoms, that's an absolute contraindication. Migraines with aura are a relative contraindication, and that will, if there's an OSCE on a combined oral contraceptive pill, I would put a bet on the person having migraines so that you can talk about something and prove some knowledge. Circulatory disease, so DVTs has been asked in exams before, and you should know that it's an absolute contraindication to being prescribed the COCP. Similarly, a smoker over the age of 35, that sounds like perfect fodder for an OSCE station or an exam question, and you shouldn't give the combined oral contraceptive pill to a person of that age. The rest, they're very straightforward. You don't give a contraceptive to someone who might be pregnant. Don't give a contraceptive that might cause abnormal bleeding to someone who already has abnormal bleeding that you haven't diagnosed yet. So again, I won't necessarily go through each of these one by one, but as long as you have a good understanding of the potential risks, benefits, and these contraindications, you should be able to counsel the combined oral contraceptive pill without having to think too much about it or memorize too much. I'll also add to this. So in many questions, or mainly questions, there are sometimes scenarios. So when something might be good for a certain demographic or a certain population. So a scenario for someone who would get a combined oral contraceptive would be probably a young woman in a stable relationship who has a low STI risk, or you know, if the option is COCP with barrier methods, it could just be, you know, any old young who might want, let's say, cycle control. And the combined oral contraceptive would be a good option for something like that. So I've got a question for you guys, and you know, if no one knows it, that's fine. So a woman, this might be similar to exam questions in the past, who knows? So if a young woman has been prescribed a combined oral contraceptive a month ago for the first time, and she comes to you with spotting, what do you do? Does anyone know what you might tell her? I won't pick on anyone because I know some of you might not have done women's before. So you would tell her to keep taking it for another 2 months. So it can take up to 3 months for the combined oral contraceptive to regulate itself and to control any abnormal spotting and bleeding. And so you would want to wait 3 months before you give any particular advice, and telling them to stay on it is probably a very safe bet. After 3 months, you might consider putting them on a higher dose of the combined oral contraceptive pill, because the doses of hormone that you're giving them at the time may not be enough to actually inhibit the release of FSH and LH enough. So that might be what you consider after that point. And this is another one. Hopefully some of you guys know this, maybe from GP or maybe from women's as well. So a woman comes to your clinic and she's missed 2 pills in a row. Does anyone know what sort of question you might ask her before giving her advice? Well, I mean, sure, yeah, that'd probably be important because you'd want to do a pregnancy test in that case, I suppose. In terms of counselling her about taking the contraceptive. Yeah, wonderful. So when in the cycle has she missed these pills, right? Because the management of what you do is going to differ from when it's in the first 2 weeks to when it's in the last week, for example. And does anyone know what you'd sort of advise in either case? Might be a bit much at this point, but. So if it's in the first 2 weeks, you take, and you've missed 2 pills, you take 2 pills on the day you remember, and then 1 per day until the pack is finished as per normal. And you make sure that you use backup contraception for the barrier contraceptives for the next 7 days, right? So tell them to take 2 pills, use the rest of the pack, and use condoms for the next 7 days or whatever. If it's on the 3rd week, or they've missed, I'm just going to ignore that, hopefully they walk in. If it's on the 3rd week and they have missed 2 in a row, then they should throw out the pack and see one. And they should also use, I don't know if I can ignore that to someone I open the door. If it's on the 3rd week, you should tell them to start a new pack and use barrier contraception again for 7 days. And you do that as well if they've missed 3 in a row at any time. Oh, awesome. All good? Okay. And if you miss 1 pill if you miss 1 pill, just take it whenever you remember, and you don't need a backup. Luckily, the combined oral contraceptive pill has a pretty big window in which you can take it, so don't stress if they've missed 1 pill. All right, so I'll continue by talking about hormonal contraceptives. So transdermal patch is another combined contraceptive, but rather than taking it orally, you put it on the skin, which has various benefits. You can put it, on the back, lower abdomen, upper arms, but you don't want to put it on the breast because it can, modulate breast cancer risk, and that's probably a bad idea. So much like you take the combined oral contraceptive pill for 3 weeks, and then you have 1 week of sort of sugar pill or placebo, you put this patch on for 3 weeks, it elutes the hormones, and then you take it off for a week to allow for menstruation. And because you're giving them some hormones that distribute into the system through the skin, the main consideration would be that it may be less effective for women over, X kilos or their BMI, just because there may not be good vascularity to the skin, or there may not be adequate distribution of the drug. So that's probably the main consideration. But it is as effective as the oral contraceptive pill. I don't have the numbers with me, but you would think that maybe even more so because it doesn't rely on compliance so much. So the NuvaRing is another combined contraceptive. It's also as effective as the oral contraceptive pill. So it has some benefits in that it's self-administered, similar to the last two. You wear it for 3 weeks and then take it out for a week to allow for menstruation. And because its main benefits are because it acts locally. So it's as effective as the oral contraceptive pill, but it also can elute lower doses because it doesn't have that first pass effect through the liver, which might metabolize half the estrogen that you give them orally. And it also has less sort of systemic effects. It may have better cycle control and less breakthrough bleeding. It's really easy to think about side effects of something like this because you've put like a thing in the vagina. So you can get some irritation. It's a foreign body, so there's a risk of infection, and you may get some discharge as well. And so those are sort of the combined options, or the main combined options that you have. And then there's the progesterone-only pill. So if you're going to remember 2 types of contraceptive, actually, no, maybe 3, I'd go combined oral contraceptive, maybe Mirena, and then the POP, or the mini pill. So the progesterone-only pill is really effective postpartum, most suitable for postpartum women, and also in those who may be like allergic to combined contraceptives or intolerant to estrogen. It's really good in postpartum women because it's not likely to affect their milk supply, unlike the combined pill. And it has obviously various effects because it's progesterone. The mechanism of action, you can really look at that in your own time, but it also inhibits the release of hormones, matures the endometrium, thickens the mucus, etc. So the mini pill is the main one. You should take it at the same time of day. It doesn't have quite as good a window as the combined oral contraceptive pill does. So you want to take it more regularly. It has a higher failure rate because of that smaller window. So quite a bit higher than the combined oral contraceptive pill. And ovulation is inhibited in a lot of women. So some women, whereas on the combined pill, you will generally have a period as per normal. On the progesterone-only pill, there's a higher risk of oligo or amenorrhea. Yeah, and I mean, the reason is that it's not used probably more often is because it has that smaller window for you to take it in. And side effects of this should be really simple. I've told you about progesterone. Progesterone sucks balls. It makes you fat, it makes you sad, nauseous, everything sort of slows down. So side effects are irregular menstrual bleeding, 20% stop because of this. It's probably the main side effect. But weight gain, headache, breast tenderness, mood changes, crappy stuff like, acne and hirsutism, and nausea. So, you can probably rattle all those off without having to memorize anything, okay? This woman hates progesterone. There are no absolute contraindications, which is why it's such a good option for when the combined oral contraceptive doesn't work. And so a woman presents to your clinic. She's missed a Popdose. Any idea what you tell her? So it's got this short window period, and it's quick to wear off, but it's also quick to work. So it works faster. You can take another pill immediately and continue to take the remainder as prescribed. And you should use backup contraception, of course, but you only really need to use it for 48 hours, at the minimum. So that's probably what you tell her in that situation. So that's the one form of progesterone, but there are many other forms of hormonal progesterone-based options for contraception. So even if you haven't done women's, you should know what a Depo is because you will have done psych. So this is progesterone right into the bloodstream, smack bang, that lasts circulating for about 12 weeks. So it's quite a high dose. It's given every 12 to 14 weeks. Give it postpartum if that's what they've chosen to go with, or you can initiate it sort of just after they've had their period. And some women like it because you can become amenorrheic. So 70% of women within 1 to 2 years will get amenorrhea with DepoProvera. And it's very effective because we've removed this compliance aspect of the whole nonsense. And so if you inject someone, it's bound to work, right? And so the main things, I don't think you'll really get asked about something like a Depo because it has such sort of, well, the things that I think you'll get asked are these side effects and contraindications. And I'm if there's going to be an exam question on this, and there has been, it's almost certainly going to be on one of these things. And the 2 things that you need to remember, or the 2 main things that you need to remember, are this bone density nonsense. So if you give them a Depo, they have a risk of decreased bone density. And therefore, you can remember the contraindication because you're not going to give someone who has osteoporosis or osteopenia something that's going to make them worse. Weight gain, it's a progesterone-based medication. You can't get away from that. Irregular bleeding, and don't give it if you don't know why they're bleeding in the first place. And this delayed return to fertility is the second thing, apart from the bone density, that I think you should know about DepoProvera. Because if you're going to give this medication to a woman and she might want to get pregnant in the next 2 years, you've fucked up. So don't choose this if they're a young woman who may want to get pregnant in the near to moderate term future. Don't give it to them in liver disease or breast cancer for reasons which I don't think are important. Great. So if this was going to be a scenario or an option where you might give this to someone, it would not be a choice in that young woman who maybe 25 or 26 or whatever and has a partner and may want to have a baby. However, in that scenario, that specific scenario, an implant may be a very good idea. So an implant is also progesterone into your system, but rather than giving it smack bang one whacking big dose in the arm, you give it through this tiny little stick, which elutes much, much smaller doses. So you can see I'm giving them 150 milligrams and you're only getting 25 to 70 micrograms a day with this. So it's highly effective for 3 years, 0 failures. There's no compliance. Even with the Depo, you have to go back every 12 to 14 weeks. With an implant, you can stick this in and leave it there for 3 years and essentially forget about it. Side effects, irregular bleeding. Now it's a painful one because about a third of women can get really annoying irregular bleeding that just doesn't go away with the implant on. And that's one thing that you might counsel someone about. Contraindications, straightforward. You should sort of get the gist with all of these. Pregnancy, don't give it to them in liver disease. Thrombophlebitis or embolism and breast cancer. The major difference between this and Depo is that you don't have those too few side effects with Depo. You don't have that bone density crap, and you don't have this delayed return to fertility because it's such small doses. Once you take it out, it's pretty much gone from your system straight away. So a GP will put a nick in, and that's sort of the applicator up there. Stick that in the arm, push in the implant on, and that's the implant in. Steri stripping it done. To take it out again, you just put another cut in and sort of drag it out. So yes, scenario, young woman wants a long-term contraceptive because they're lazy or can't remember the pill or, I've been there. It's quickly reversible. So you don't want to yank out a Mirena, for example, on a nullip cervix. That would just be like the worst. And you don't want to give her a Depo because every 12 weeks is a pain. Speaking of Mirena, so IUD is, I think, the last sort of hormonal form of contraception that I'll talk about. And it is, like I said, sort of important to know. I'd say probably you'll get the most questions on this after the combined oral contraceptive or maybe the progesterone only, just because it's so common nowadays for women to have it, particularly middle-aged women. Again, it's highly effective, reversible, private, convenient. So like most of the long-acting ones, you use in those who request long-term contraception or have difficulties with other contraceptive pills. So side effects, breakthrough bleeding, they can have expulsion, particularly in the first month after insertion or in nulliparas. The uterus just might be like, nope. Uterine perforation, it's 1 in 1,000 on insertion. You've got this like whacking great sort of stick thing that you put up there and inject kind of the Mirena into the uterus. So, there's always a risk of perforating when you stick anything up into the uterus. And for that reason, you want to wait until 6 weeks postpartum to put one of these in because there's a much higher risk of a perforation right after they've had a delivery. There's obviously an increased risk of ectopic because you've just put a thing in there. And similarly, there's about a 30% rate of miscarriage if they have an IUD in utero. So if they become pregnant and, they might want to keep pregnancy and they've got an IUD in there, you want to take it out straight away because there's a high chance of ectopic or miscarriage. Presumably they don't have any ectopic in the first place because then the pregnancy is not viable, but it's neither here nor there. And there's also an increased risk of PID within 10 days of insertion. After that 10 days, that risk is no longer really, it's pretty negligible. And the one sort of buzzwordy type potential question thing would be this picture. Anyone know what it is? Bonus points if anyone can tell me, take a wild guess based on what they might know about IUDs. No, not quite. It's actinomyces. So there's a specific, that's the specific infection that IUDs put you at particular or kind of special risk of, or buzzwordy risk of. I'm not really sure if it's any more likely than a different type of infection. But actinomyces related PID only really occurs in intrauterine device insertion. And remember, people aren't protected against STIs with a lot of these sort of long-term contraception. So talk about barrier methods as well. So there are two types of IUD, copper and sort of hormonal. They both last 5 years. Copper, you can get sort of a 10-year one. So copper works by, it's basically a thing in there that just causes your uterus to be really sad. So it causes a foreign body reaction. I say uterus really sad. It's both, you know, in the endometrium and with the sperm. So it just creates an irritation constantly, which, you know, does the job, I guess. But the thing is, I don't know why anyone would actually choose this, because it has a higher risk of dysmenorrhea, which is the worst. And it can also increase your blood loss and duration of menses, which, like, total fucking nightmare. So, you know, maybe someone wants it, don't know why. Progesterone releasing IUD is much more common. It causes, you know, much like all these hormonal things, the decidralization of endometrium, thickening of cervical mucus. You should all know this by now. I've probably said it about 4 times. Last 5 years, and, you know, it's got all those bloody progesterone side effects, fat, sad women. So clinical scenario for a Mirena, and, you know, these scenarios do come up in questions, and you have to sort of pick the best contraceptive option. So a scenario might sound like a middle-aged woman, done having all her kids. She's got a bit of pain, dysmenorrhea, and she wants some long-term contraception. So you probably, in that case, suggest something like a Mirena to her. Okay, yeah, and this is another table that I won't really go into. You guys have the slides. I might sort of go into. And so you should, you know, be able to kind of guess what you know, when you totally wouldn't put one of these in, or when you maybe wouldn't put one of these in. PID, if they've got an infection in their uterus, you're not going to put a thing in there because it's just going to get, you know, more infection on it, and that's not going to help anyone. It, you know, might create a foreign body for all this infection to sort of attach to, so you can't treat it as well. So don't give it to them if they have an infection. Don't give it to them if they're pregnant. That's really a bad idea. Don't give it to them if they're going to, you know, they may have irregular bleeding as a result of having the IUD. So if you don't know what their bleeding is, don't give it to them. If they're allergic to copper, don't put copper in there. If they have Wilson's disease, don't put copper in there. So the yellow ones, or the brown ones, by the way, are specific to the copper IUD. And relative, I mean, you know, if they're likely to get PID, probably don't give it to them. If they have an ectopic, you're just going to increase their risk of getting into ectopics. And if it's going to be difficult to put it in there because, like, you know, they might have cervical stenosis, or they might have abnormalities within the uterus, probably not a good idea to try and put an IUD in there. And there are other options that you can discuss. The others, you know, you might just want to know. They're in your textbook: immunosuppression, prosthesis, valvular heart disease.
Did you ever take an IUD?
Yeah, you should take it out, and then you should treat the infection, because I mean, go back and look this up, but I'm, you know, from what I remember, it's been quite a while since I did 4th year. But you would imagine that because they have an infection in there, it's just, you know, there might be bacteria that sort of attach themselves to the device. And you can always put another one in. So yeah, I mean, most things, benefits, risks, contraindications, side effects, you can have a pretty basic, good understanding of if you understand the components within the contraceptive that you are suggesting to the patient. And so don't be scared by all these things. Don't be scared by how many types there are. If you sort of know, okay, you know, these are the benefits and these are the particular risks based on these factors of the contraceptive, contraception isn't actually that difficult. So barrier methods, it's important to know, again, that the only way to protect against STIs, condoms, I hope you all sort of have some idea about. Diaphragms, they need to be fitted by a GP or a gynecologist. You insert them 6 hours before intercourse, which requires some pre-planning, I suppose, and then they can be removed up to 6 hours afterwards. And, you know, you're putting a thing up there again, so there may be some irritation. This is like, I like this picture because it's sort of like a wedding ring, but it's kind of also very much not. So female condoms, I think that looks horrifying, like some kind of sci-fi worm, but they're actually the most effective barrier method against STIs because they have such a large surface area. So, you know, if you find someone willing to use them, then great. And there's the natural planning methods, which have been asked about. on previous exam questions, which really annoys me because it's really hard to find good information on, you know, what's best. But anyway, so the rhythm or the calendar method requires your cycles being super regular. And it pretty much implies that you can look at a calendar and know when you're going to be having your period and when you're going to be ovulating, and because your cycle is just that regular. And so if you know when you're going to ovulate, because you have a very good idea of when your cycle is going to be, you can look at that calendar and say, okay, well, I'm not going to have sex 1 week before and after I ovulate, because that's when I'm going to get pregnant, and I'll have sex every other time. So that's the rhythm or calendar method. Billings has been asked about. It's based on sort of being able to self-evaluate your own menstrual cycle through things like cervical mucus. And so you should abstain when there's ovulatory changes in the mucus, which is when it's sort of thin and clear, apparently, and increased volume. And there has been a question on the Billings method. They shouldn't have sex when there's those ovulatory changes, and they should abstain for 3 days after those changes kind of finish. So that's sort of the Billings method. And there are various other addendums to that. You can kind of look into it online, lots of craziness surrounding it. Symptothermal, so a good way to sort of know when you're ovulating is by measuring your temperature, your body temperature raises 0.3 degrees when you're ovulating. So some women can sort of judge based on that. And breastfeeding is quite a good contraceptive. I say quite a good contraceptive because there's it's sort of 98% effective, but I would not want to be that 2 in 100. So you should probably recommend they go on the pop or something of the sort. Yeah, these parents didn't work it out. So I'm not going to talk. So emergency contraception is a whole other topic in and of itself. And I'm sort of going to look at the time so that I've almost gone for half an hour already, which is a bit of a pain. So I'm not going to go too much into them. I've sort of created a way to kind of divide how you think about them, so that it sort of becomes easy to come to terms with the benefits and risks of each. So there's sort of progesterone-only methods, combined estrogen and progesterone. You can put a thing up in there, which is the copper IUD, or you can give, rather than giving them a dose of progesterone, you can give them a progesterone antagonist. And they each sort of have their own benefits and risks based on this. And if you understand, again, the concepts behind the different types of emergency contraceptive, you can sort of talk a bit about what the benefits and risks might be. So a combined estrogen and progesterone method is going to cause more nausea and vomiting, because estrogen can also cause that. And if they're going to have more nausea and vomiting, they're more likely to vomit those pills back up, right? So it has a higher failure rate. And the two sort of the pill methods, or the hormonal-based pill methods, the progesterone only and the combined, they should both be taken within 3 days. And that's pretty much all you need to know about those two, aside from maybe the doses if you have to counsel it. I've never seen it come up before, but maybe you do. If you put a thing in there, it works better. So copper IUD can be used 5 to 7 days post-intercourse, and it sort of prevents implantation of the sperm. Progesterone antagonists, so that would be mifepristone, or RU486 is the other, jargon term, can also be used over a longer period of time, so 5 days. But it's usually used as an early abortion agent, and therefore it's a bit more intense. So they get quite severe abdominal pain, severe nausea and vomiting, and there may be a delayed onset of menstruation. So once you've sort of taken them through this emergency contraception, if it's a counseling station, you still need to make sure of two things: that they're not pregnant, do a pregnancy test, check it in 21 days, and make sure that doesn't happen again. So give them some advice on, contraception methods, and talk about something that might work for them. And I really should be snapping through a bit quicker. There are also permanent methods of contraception, which, vasectomy and tubal ligation are probably the only two you need to know. And so benefits and risks of either, you can go through this again in your own time. Vasectomy is safe and cheap. It can be done under local, pretty much bloody anywhere. This Dr. Sniff thing I've seen on the Frankston freeway advertisements for it. So, it's safe, cheap, really easy to access. It's not as good as tubal ligation. So there's a 1 in 2,000 failure rate. Better. Make sure you do, there's just more complications, and the reversibility is not as good as tubal ligation. You can learn about when you'll do this sperm analysis. Complications, it may cause hematomas, which seems obvious. It can also create like a reaction, autoimmune reaction sort of against sperm. So you can get these anti-sperm antibodies and granulomas. Tubal ligation sort of is a bit more high risk. So it's very effective, but you need to do it under GA generally, or laparoscopy. It can be done transcervically, but I've never seen it done. And so those are probably the only things you need to know. So vasectomy doesn't cause impotence, doesn't cause cancer, doesn't cause cardiovascular disease, which is some sort of misconceptions that might get brought up in a counselling station, but highly unlikely. And the last thing that I think might come up in an exam is when you stop contraception. So you've got a 48-year-old woman, she's come into your clinic with menopausal symptoms and 6 months of amenorrhea. Hands up if you'd stop her contraception. Hands up if you'd continue it. Okay, and all on the fence, the rest of you. So women under 50, like this woman here, should use contraception until 24 months, so 2 years after her last period, no matter what, right? Women over 50 should use contraception until 12 months after their last period, which is, you know, technically menopause. So just know that it's come up before. All right, I've got to snap on infertility. What is infertility and when should someone be assessed? So the definitions here have been asked before. So primary infertility is an inability to become pregnant in the first place, and secondary infertility is an inability to become pregnant where they've become pregnant in the past, and that has been asked, please remember. Secondary also doesn't count if they got pregnant in the past and they used assistive reproductive technologies like medications and IVF and stuff. That doesn't count as secondary infertility, that's still primary. In general circumstances, 80 to 90% of couples should conceive in a year, and you can assess after that point in young people, like below 35 is young, who have had unprotected intercourse, which is proper intercourse. Now this is like not a joke. If you are a gynecologist, or you are bound to have people who have put the wrong things in the wrong places that have thought that they're doing it right. I heard horror stories from my mentor in Mentor Week. And frequent intercourse, what does frequent mean? 2 to 3 times a week. Because, you know, this can vary for different people. And you can assess earlier in some populations. So if they're over 35 or if they have risk factors for infertility, then you might assess them before a year. I'm not going to go through these, but know your counselling for infertility. I feel like it could come up. And I say that because, to be honest, what you should be practicing is your Gareth and Weston book. You know that blue and yellow one that Monash sells? I hope you all have it. If you don't have it, you should get a copy, or you should borrow a copy, or you should steal a copy. I don't care. But make sure you have it, because every OSCE scenario I got was out of that book. It was almost identical. It was like totally out of that book. I had this weird hepatitis B one, which, you know, you would never actually expect to come up in a women's OSCE, but, you know, lo and behold, it's there word for word in one of those medical student sections of that Gareth Weston book. You know, those people who had gone through the medical student section, it's not that long, and had memorized all the scenarios in that section, you know, we're going to get 100% because it has everything in it. So you would be a fool not to go through that book and know it well. That has pregnancy counselling in it. Oh, sorry, infertility counselling. So just learn that. There's no point being caught out when the answers are right there. Again, I'm not going to go through this totally. You know, if they're not having sex often enough, they're probably, you know, not going to conceive. If, you know, they're smoking and drinking alcohol, that can reduce sperm's effectiveness, and it can reduce smoking can reduce fertility in females. So ask them about various risk factors for infertility, and preconception advice is important. Tell them to stop smoking and drinking and taking drugs. Tell them to start having sex regularly and take folate, because folate should be taken prior to conception, at least 1 to 3 months beforehand. You want to check their rubella titer, because the rubella vaccine is potentially teratogenic. So if they're not protected, you want to give it either prior to conception. So when they're worried about infertility is probably, you know, a time prior to when they might want to conceive. Or if you find out, you know, during their pregnancy that they don't have enough titers of antibodies, you give it to them after they give birth, because you can't give them the vaccine while they're pregnant. Stop any drugs. So NSAIDs reduce fertility. Chemotherapy is really not good if you want to have a kid. You know, some other random drugs like cimetidine, androgen, stop those and switch any teratogenic medications that they have. So when I think about fertility or infertility, that's more like, you kind of have to break it down into certain groups so that you can remember it a bit easier. And the way that I sort of like to do that is by anatomy. So ovarian factor is the most common, so anovulation, more like it. And then there's tubal factors, uterine factors, cervical factors, peritoneal factors, and peritoneal factors is just another way of saying endometriosis. That will fuck your shit up if you want to get pregnant. And male factors, it takes two to tango. And you can test for each of these kind of in different ways, which sort of makes sense if you know how to think about them. And I'm not really going to talk them all through, but you've got the slides, so have a quick look, and I'm sure that you'll sort of understand it anyway. So the first one and the most common one is ovarian factor or anovulation. And I've chosen this picture because it says the hypothalamic pituitary ovarian axis is complicated, and it's true. But anything that disrupts this axis or your kind of homeostasis of this axis may interfere with your ovulation or your ability to ovulate. So, you know, if you have a particularly high BMI, particularly low BMI, if you have PCOS, which kind of interferes with some of the hormones in the system, thyroid issues, some drugs can interfere with it. And again, things that interfere with your homeostasis. So if you're stressed, if you have eating disorders, intense exercise, you know, severe kind of internal disease, they're all going to interfere with your ability to ovulate or the likelihood of you ovulating. What's the number one cause of anovulation? It's been mentioned. I've mentioned it tonight. Anyone know? PCOS. Anyone know this is maybe a stretch. Anyone know the Rotterdam criteria for PCOS? It's okay, but I think you should know it. So PCOS is the most common cause of anovulation, and the Rotterdam criteria is 2 out of the 3 of these things here. So 2 out of 3 of polycystic ovaries, that's the definition, raised testosterone either clinically or biochemically, and 6 months of oligo or amenorrhea. Kind of know that because PCOS is so common, you might get a counselling station about it. And anti-Mullerian hormone can be an indicator of ovarian reserved, and there's been a question about that in the past. There's no specific reference range because it changes with age, but just know if they have a very low level, they probably don't have that many ovaries. Let me just actually check that that's true. Yes. And if they have a very high level, they probably have, you know, enough follicles or eggs or whatever present. And before I go to the next slide, I'm going to ask you another question just because I'm a sucker for punishment. So you have 30-year-old woman who has cyclical lower abdominal pain and 18 months of infertility. What is like your number one differential diagnosis? Endometriosis, that's right. So that's the sort of another, so peritoneal factor is endometriosis. So it can really interfere with your fertility because it's sort of like inflammation from all these deposits around your peritoneum, etc., which can cause adhesions, which distort your anatomy. They can cause these massive blood-like filled sacs. It's just really unpleasant. There's endometriomas, which can damage ovarian tissue. When you cut them out, they can damage your tissue as well. And all this inflammation has cytokines and growth factors, which also interfere with your ovulation and fertility. Cervical factor, if the sperm isn't going to enter the uterus, you're not going to get pregnant. So that's generally things that, you know, congenital malformations, trauma to the cervix, say from stenosis. If they've had a DNC or some instrumentation to the cervix, that might affect their ability to become pregnant. Male factor, so for a man, think about everything from the testicles all the way to ejaculation. So if they have had infections in the past, inflammation, congenital malformations of the vas or epididymis, if they've had a vasectomy, that's probably not a great sign. And ejaculatory dysfunction, which can be, you know, due to anything from idiopathic factors to drugs. So antidepressants are a major one for problems with ejaculation. And metabolic and systemic disease, so diabetes, multiple sclerosis, both of those are going to cause issues, you know, among many more. Tubal factors, so for the woman, she might have obstruction to her tubes if she's had PID, endometriosis again, adhesions, infection. And in the uterus, there can be congenital anomalies. Having a septate uterus is probably the worst, or, you know, fibroids in the uterus can also really interfere with their ability to become pregnant. So again, just think of all these factors. The factors are not hard to remember. You just sort of go around and remember that there's one in the peritoneum and one that the guy has. And then kind of just think of things that really fuck them up. And that should really just give you a list of things inside your head that you can at least rattle off 3 or 4 for each of them. So again, infertility is not that complicated. It's just, having some kind of breakdown in your head. Investigations, I don't really want to go through particularly. These are all in your Gareth Weston books, which you should be memorizing, I hope, by the end of the year. And I say memorizing, it's not a joke. Really, you should be memorizing them. So there's not that many. But anyway, you should, as I mentioned, you should investigate after a year if they're under 35 to 40, let's say, maybe 6 months, and above 40, you should just investigate them immediately because fertility is much less likely. Earlier, if there's been some problems in the past, say, PID, endometriosis, or pelvic surgery, recurrent pregnancy loss, you should investigate them earlier. I bolded sort of the tests that you might do in a GP type scenario. And I will highlight that semen analysis has had questions on it that sort of relate to specific values. There'll be kind of reference ranges in most textbooks that you have access to have some kind of a vague idea on what you would expect to be normal in a semen analysis. So just so that you can know what's totally abnormal. And they're not going to pick something that's like, a few values out of the reference range. They're going to pick something that's totally wrong. And mostly that'll be to do with whether they have normal sperm count or whether they're azoospermic, etc., or oligo, whatever. So just kind of have a vague idea of those numbers. I'll just say, so prolactin can interfere with your ability to ovulate because it interferes with your hormones. So that's why you might measure that. And androgens or sex hormone binding globulin may be raised in PCOS. So that's generally kind of what you sort of test that for to find out. And there are further tests that you can do if you go through all these basic tests and don't find anything. You can do a laparoscopy. You can do thyroid function tests, which may also inhibit or interfere with your fertility. And treatment advice, I really, again, don't want to go into specific treatments, but, make sure you give them general advice first. Make sure they're ovulating because that's the most common reason why they might have infertility. So you can give them a kit to test, if they're ovulating, which are available at the chemist. Give them advice on smoking and weight. In the case of PCOS, for example, 55 to 100% of people will improve their fertility if they lose weight, if they're overweight. And for people who are underweight, pretty much 100% are going to, or 80% really, are going to return to being fertile if they gain weight to a normal level. So there's some simple things that you can advise. Again, smoking, alcohol, you can refer them to counseling because it can be quite taxing on people. And you can consider medical therapies. So like I said, I'm not really going to go into them actually. I'll mention clomiphene citrate because that's probably one that you might get asked about. It's a SERM, so a selective estrogen receptor modulator. It has estrogen antagonist and agonist effects to increase the release of gonadotrophins from the pituitary. It should only be used for a year because when you are fiddling with your gonadotrophins and increasing your hormones, it can increase your risk of certain cancers, as you would know. And 70% of women will ovulate on this. And you really want to do an ultrasound of their ovaries quite regularly because it's so good. A lot of women will have multiple mature follicles at any one time, and they have a high risk of multiple pregnancy. So 10% of women will have multiple pregnancies. And if you have 3 or more mature follicles at any one time that you can see on ultrasound, you should tell them to not have sex because no one wants to have triplets. Really, no one wants to have triplets. I say that some people might have, one of you might have triplets, and that's great. But as someone who has seen parents who have had triplets, it seems traumatic. I won't really, so metformin is used generally in PCOS. It obviously also regulates your glucose. HMG, or human menopausal gonadotrophin, which is derived from the urine of menopausal women, which I find incredibly disturbing. It is sort of an LH and FSH combination. It sort of works similar to clomiphene citrate, except cutting out the middleman. Won't talk about the rest of them. Bromocriptine and dopamine agonists is if they have hyperprolactinemia. That's generally what that's used for. IVF, it's a big topic, and I've never seen it asked. But I mean, I'm not going to tell you how it works because it's really complicated. If you sort of have a basic understanding as to how it works, maybe, you know, I know that we have several IVF people involved in the Monash course, and maybe it'll come up at some point. So if you have a vague idea of sort of how it works, I don't think you need to know that much about it. But, you know, have a look at it in your own time. One thing I have seen asked about, which sort of relates to using these medical therapies to sort of stimulate the ovaries, is ovarian hyperstimulation syndrome. And this happens because you've stimulated these ovaries with all these hormones, and they sort of go crazy. They get over luteinized, they have all this vascular endothelial growth factor, so they get huge vessels. The vessels become leaky, and it can shift fluid out of the intravascular space and cause mayhem, essentially, which can range anywhere from mild, with pelvic discomfort, where you just observe them, to moderate problems, where they might have a bit of discomfort, and you sort of don't want to do any invasive exams, to severe, where they can get ARDS, they can get ascites, pleural effusions, really unpleasant. And in that case, they need hospitalization. And obviously, you don't want to give them any more medications in that case. How are we doing for time? I see 48, 55. Hopefully, I'll get us out of here not too long from now. Antenatal care, I'm just going to hit the buzz topics, essentially, I think, because, you know, you're not going to be asked to counsel someone through the entirety of an antenatal care plan. So I'm completely going to skip this. The regimen for antenatal care is not that important, and you can learn it in your own time. At the first visit, I've seen a question on quantitative beta-HCG. So you want to do all the normal things, offer them a pap smear if they haven't had one before, you know, do their blood pressure, their urine, all of that. Beta-HCG. So there's been a question on when can you detect it, or maybe there's been a question, I should say. Urine, the lower level is about 20 to 50 international units of HCG, depending on the test, obviously. But if you see values that are quite similar to that, you know, you can be pretty safe. Serum, 5 to 10, bit more sensitive. There are these ultra-sensitive tests, or hypersensitive, which can detect 1 to 2, but I don't think they'll ask about something like that. And you can do a dating ultrasound. Talk to them about wishy-washy things like their options for care and their classes and diets and vitamins, etc. Folate, always remember folate. And you order their tests for their booking visit. And this is the important one. So as you want that first visit to check that they're pregnant, confirm that they're pregnant, and order all these tests. And during the booking visit, you'll discuss the results, right? So you should have them all in front of you. You should know what tests to order when. This is all in Gareth Weston, so you should be memorizing that, as I've said, and kind of know why you're ordering each of them. So you want to know their blood group and antibodies. You want to know if they're rhesus positive or rhesus negative particularly. You want to know if they're anemic, to know if you want to start them on any iron supplementation. Same with calcium. Vitamin D, not everyone orders vitamin D by default, but you will definitely order it in, say, a woman with darker skin, because she's at higher risk of having vitamin D deficiency. Check them for a range of infections. Hepatitis B, like I said, I had that horrific OSCE on it, which still traumatizes me to this day. But the basic management, if they are hepatitis B positive, is at birth you'll give them hepatitis B immunoglobulin, and then you'll vaccinate them afterwards. HIV, if they're positive, you'll give them antiretrovirals during the pregnancy, deliver via cesarean, give the baby antiretrovirals, and say don't breastfeed, please. Syphilis requires 2 tests for confirmation. One's very sensitive and one's very specific. Rubella, which I've talked about before, and varicella, particularly if they don't remember if they've had an immunization or if they've had any exposure to it in the past. Not everyone will test for it. And you'll do their urine, of course. There are various extra tests which you'll order if they're at particular risk for certain things. Chlamydia if they're 24 or under generally. Hemoglobin electrophoresis for specific ethnic groups generally. Hepatitis C if you think they might be at high risk. Thyroid function, glucose tolerance, CMV, particularly if they're a healthcare worker, or toxo if they have cats, for example. But, you know, just have a general idea. One thing that gets asked about extensively, and is probably the most high yield topic in antenatal care, is trisomy 21 testing. There have been questions about what you test for, if it's raised, if it's lowered, when you test for it. There was maybe a question about, you know, what weeks you test for a certain thing. So I know this inside and out. So you should, all women should be screened, or should have the option available, I should say, sorry, for trisomy 21 testing. And there are screening tests, and then there are diagnostic tests. So you counsel them before the screening. You know, if it's positive and they keep the fetus anyway, then maybe you don't screen them. If they've got so what happens is you have the screening test, and if you're deemed to be at high risk, then you go on and have a diagnostic test. And what is high risk is anywhere from 1 in 300 to 1 in 250. So if they're 40 years old and their risk is already 1 in 90, you probably shouldn't bother with a screening test. So these are the sort of things that you'll talk to them about. And you should know everything on this slide. I don't care if you fall asleep with the slide in front of your face, or print it off and stick it on your roof, or shower with the slide right in front of you. You should know every figure and number on this slide, because I think there's been a question on one part of the slide in every exam, and you may get counseled on it as well. And there's really not much point me talking through it totally, but first trimester, you want to do the bloods at 10 to 12 weeks, ultrasound at 11 to 14, and high risk is 1 in 300. You kind of just have to remember those. I don't know if you come up with some kind of mnemonic. I know for the second trimester one, I sort of put them in alphabetical order. So AFP, estriol, HCG, and inhibin, and the first two are decreased and the next two are increased. But, you know, you might have your own method of trying to remember that. And also know kind of the miscarriage rates for the diagnostic tests. Amniocentesis is a bit less likely than CVS. So it has 0.5 rather than 1. I've had some obstetricians try and tell me that that's because it's done later in the pregnancy, and therefore there's just a general lower risk of miscarriage. But I mean, I haven't read the evidence surrounding that and be able to tell you either way, but that's how I remembered it pretty much. Supplements, you can read this on your own, but folic acid gets asked about. One, because you have to start it early, and you have to know that you have to start it early. And two, I think the question, actually, I can't say it, but you know, it's necessary no matter what the woman is, or, you know, what she has, even if she has no deficiency, she should be on folic acid. All the rest of the supplementation, so vitamin D, iron you should give with juice because vitamin C increases its absorption, and calcium you will only give if they're deficient. Folic acid, you give it to her no matter what. They've also had questions about dosages. So if she's had no prior problems, give her 0.5. Times that by 10 if she has. So if she's had a past neural tube defect, or she's on anti-epileptics, which might interfere with her folate, then you give her 5 milligrams per day rather than 0.5. There have been, so here are the main things I would point out. You give anti-D at 28 and 34 weeks is when you give them shots of anti-D if they're rhesus negative. And remember sort of the threshold limits for the glucose challenge test and the oral glucose tolerance test, and when they're done. I think that those are things that have been examined in the past. So you want to check if they have, every woman should have a glucose challenge test where you give her 50 grams of glucose non-fasting. That fails if her glucose is above 7.8 millimoles per litre at 1 hour. And then if it fails, you should give them the oral glucose tolerance test, which is a bit more involved because they have to fast. It's a bit of a higher amount of glucose that you give them to drink, and you measure their blood sugars twice. And there's 5.5 at 0 hours is for gestational diabetes, and above 8 at 2 hours. And there has been questions on that before. GBS is probably the other sort of antenatal care topic that has lots of questions asked about it. So it should be tested at 36 weeks with a vaginal and rectal swab. When you're on women's, you'll see zillions of these. And if it comes back as positive, while they're delivering, you give them a 1.2 gram loading dose of benzyl penicillin with an extra 600 milligrams every 4 hours if they're positive. If they're allergic to benpen, clindamycin is an adequate alternative. There are a few other alternatives that weren't asked about, but I mean, you can learn if you'd like, and probably should, I guess. And if GBS status is unknown at birth, then you should know a bit about what you should do in that situation. So if it's unknown, you should give them these antibiotics if they have any risk factors. And these include premature labor, if they spike a temp, particularly during their delivery, If they have rupture of membranes greater than 18 hours, if they've had a previous infant with GBS, if you've detected GBS in their urine during their pregnancy, and if they've known to be carrying GBS in the past, then they should definitely get antibiotics during delivery. This is towards when they're delivering, and it's very basic things. None of these things have been asked about. And after term, then you can consider ordering a cardiotocogram to check how the baby's doing. And once they get to 41 weeks, you can offer membrane sweeps and do all of that and discuss the management of prolonged pregnancy. But overall, I think out of all these three topics, antenatal care is probably the least sort of asked about. And there are only those few key things that I really think are actually touched on in exams and in OSCEs. So that would be GBS, trisomy 21 testing, and the booking visit tests and results. The other thing to do with trisomy 21 is that I was going to put a slide on it, but I just thought that it would be not really relevant because it's more to do with pediatrics. But one thing that is on exams constantly, and I had a whole station on, is Down syndrome features, or what a woman who tests positive to trisomy 20, well, who is at high risk of trisomy 21 might want to know about would be all the potential complications of Down syndrome in an infant, and what they might develop in later life. So that's another topic that I would recommend that you are highly familiar with, as it is no doubt going to be asked in some way, shape or form, whether it be on the women's or the peds exam. And pretty much everything else that I was going to cover today will be on the slides, and you should probably go through in your own time, because me talking about it briefly now is not really going to drum that into your brain. But yeah, take away the highlights, take away the things that I've tried to emphasize, and good luck for your exams. I'll try and wrap up because I don't think I can hold anyone's attention past an hour and 10 minutes. Thanks, guys. No worries.
Thanks so much, Tori.
No, all good.
Hey, Tori.
Hey, yeah, not too
Thanks for
bad.
the lecture, and cheers for helping me with the delay. And
Oh, yeah.
Yeah, so I started BCG in the end. That week was a very busy week. That was the week to do the GPR presentation. I also had like extra stuff, so I didn't have much time to prep, so I didn't get through to the second one.
No worries at all.
But for that one, I was actually, to me, it was more fun to get the internship which I was quite happy. I'm happy to get the work because that's the last future. So I'm going to do 4 weeks and then go to Europe for 6 weeks.
Wow, congrats.
Yeah.
Oh, that's amazing. Oh, cool. No worries at all. I'm glad that you hopefully had a good experience at least and learned a bit.
Like the BCG case was really interesting as well. Like the feedback I got was, I think they could tell I hadn't done much prep. But they said, like, if I do prep well in the future.
Bear in mind, you've got a few years to do it, and like even if you don't want to apply for jobs, but I'm glad that you sort of got something good out of it, and congrats on the choice. That's awesome. That's really awesome.
Yeah. All right. Cheers.
No worries. G'day. Yeah. Hopefully I can answer it. Yes.
Like, if the egg takes 5 days, is that right? 5 days?
Yeah.
So why do you guys on that day?
Look, I don't know. Look, it's a good question. It's a great question. You should ask it. I'm sorry. No worries. Hey, you. No worries. See you later. Whoa, hello.